Excellent. So we're going to talk about distal radius fractures and the anatomy of distal radius fractures. So we know about the loading of the distal radius, how it passes down from the lunate, particularly to the volar aspect of the lunate facet, and that this loading passes all the way down to the volar cortex of the distal radius. There's also some loading across to the dorsal aspect of the radius with these trabecula which span across to the dorsal cortex. If we look at the subchondral bone plate in a higher magnification, we can see that in cross-section that you have these primary, secondary and tertiary layers of the subchondral bone plate, and in higher magnification again you can see that these are like spherical voids, particularly at the level of the subchondral bone plate. And in cross-section this is similar to an I-beam, but what's interesting, it's not just an I-beam in this plane, it's obviously a three-dimensional structure because it goes all the way right across the cortex, but then goes in multiple layers. Our engineering colleagues would refer to this as a sandwich panel, and we know from fractures of the distal radius, you'll often see the whole subchondral bone plate as one fragment. So the subchondral bone plate is 2 millimeters thick, it's strong, it absorbs impact, resists bending and compression, and transmits load. So if we have a look at the sagittal plane of the scaphoid facet, and obviously this is an osteoporotic specimen, so this is done with a micro CT. We can see the subchondral bone plate nicely, and we can see how the trabecula span down from the subchondral bone plate, and it creates a vault in the superior aspect, but also the shape of this is described as being parabolic. That's the best shape to be able to transmit the load from the subchondral bone plate to the cortex. So the structured architecture is important. The way that we think of this, though, is really it's a bit like the old-fashioned railway bridge where you have this lacing across the top of the, and trusses at the top of the platform where the train would sit. Then you have this intermediate trabecula passing down to the arches, and then this goes down and the load is transmitted to the diaphysis. So the load transmission is important. So if we look at the cross-section going more towards the metaphyseal and almost towards the diaphyseal region, we can see that there are these longitudinal ridges that are within the endosteal canal of the radius, and between them, though, that there are like wouldn't quite say defect, but we can see here how it's grooved, and this is likely to be a line of weakness and an area through which fractures are likely to propagate. And many of you have come here to Adelaide on an aeroplane, and so the aeroplanes have these what are called stringers, and these provide support for the aeroplane to make the fuselage stronger, and it's important to prevent buckling, compression and torsional injury of the aeroplane and also of the radius. So we think a little bit about the fracture theory of fracture theory. Basically, the bone can be knocked off or it can be pulled off by a ligament. And if we have a look at this radius, we can see how that there's initiation of the fracture, there's propagation, and it will propagate through to the areas of least resistance. And we can see here on Lister's tubercle across the back how that seems to be protected, and the force is transmitted either side of Lister's tubercle to the floor of the fourth and second compartment. So in our practice, and I think probably in your practice, these are our patients, the older ladies and the more aggressive males that have high energy injuries. And if we have a look at 100 fractures which we put on a template with CT scans, we identify the sites of where the fractures occurred, and we identified these vulnerable areas, and we tried to work out what was really going on. But I think the most important message that we got was that where the ligaments were tended to be less fractures, and so the fractures tend to occur between the ligaments. And so this is I think this is an important finding, not just for distal radius fractures, but in fact all fractures. So the ligaments are associated with the location of the fractures. So with regard to, if we look at all these radial styloid fractures, there's actually no fractures in that 100 cases that go through the tip of the cortex of the prominence. And so when we look at this micro CT, we can see that there are bridging, bracing trabeculae across the corner here, and we think this might be one reason as to why there are no fractures at that level. And if you're going to provide stability for, say, any sort of construct, so even an elbow fusion, you might like to put a brace across it to provide better stability. So from how does we think fractures occur, we know about the importance of the volar capsule, And if you have the wrist and we go into extension, you can see the tension band effect of the volar capsule, creating increased force and pressure will be going particularly at that aspect of the subchondral bone plate. Interestingly, as this is now placed under some tension, it'll be the undersurface of this subchondral bone plate that will be under tension, and we know bone is more likely to fracture in tension. So as we go into greater degree of extension, we'll get a propagation of the fracture, and Pecklander described this in detail in a cadaveric study over 15 years ago. And if we can see here that we get more dorsal comminution of the radius. And what's interesting is to look at the position of the extensor retinaculum. So the extensor retinaculum is passing across the fracture at this level, and the comminution is just proximal to the extensor retinaculum. So we postulate that the extensor retinaculum with its soft tissue attachment to the distal radius provides some support onto that distal radius, and then the fracture tends to occur just proximal to it. So whether the extensor retinaculum and the ligaments actually tend to absorb some of the force, or whether they tend to reinforce the bone, we're not totally sure of, but we do know that the fractures occur away from that actual capsule and ligament attachments. So as we go further, we may get a volar avulsion as this volar capsular structures pull off the volar cortex. So at the time when we see our patient, they may present with some shortening, there may be some comminution, and then we take them to the operating theatre, and we would often do ligament ataxis. But we can see here, this demonstrates nicely how the fracture doesn't reduce properly. We don't have an anatomic reduction of the distal radius articular surface, particularly because the dorsal capsular structures don't have the same tension applied on them because of the ligament orientation. So we do an anatomic reduction. In some patients, we would have a void here. We don't tend to always bone graft it, but it's something that remains a point of discussion. And then we go ahead and we might use volar plating. We're very lucky to have George Orbay here today, who was the one who really promoted this whole concept for us. So we looked at a series of the 100, and then we looked at 42 patients in the same series who had two-part fractures, and this is that cohort, and we can see that 87% of the fractures occurred through this same area. So it's 87% of the fractures occurred in this 48% circumference. So again, the fractures in the two parts are between or adjacent, probably adjacent to the ligament attachments. And the other thing that was interesting, every low velocity fracture that we saw fits this concept. It's only the guy that's skydiving, motorbike, all those sort of things. They have fractures that occur in other areas, but the low velocity injuries, all of them basically fit into this configuration and concept. So the magnitude of injury is important, the ligaments are very important, and this is really a reproducible type of fracture and one that you see in your practice. So what about scaphoulnar instability? These are all the two-part fractures, and what I found very interesting, I remember going to the academy many years ago and Richard Gelberman told us if you have a radial styloid fracture, you've got scaphoulnar instability. And I believed that for a long time, because I believed a lot of things Richard Gelberman said. But we see here, the ones on the top right are the patients where we identified widening of the scaphoulnar interval. So the scaphoulnar interval are the fractures more likely to occur through the lunate facet more so than the radial styloid fractures. So if we look at our two-part fractures and we think about how we might manage them, so clearly we need to buttress this type of fracture. These may be associated with instability of the dorsal radius, distal radioulnar joint. Again, we may need to buttress these and provide stability for all of these type of fractures. So the concept of where the ligaments are important made us realise, well, wait, there's a ligament attached here, and there's a ligament attached there, and there's all these ligaments in specific positions. So wherever there's a piece of bone, one of the primary bone fragments, we know that there is a ligament primarily attached to that. And so this is what I call the osteoligamentous units and the osteoligamentous concept of fractures, so that we can identify all of these specific ligaments and how the fractures occur with them. And so if we try and work through this a little bit more clearly, we can see that if you have this type of fracture, you may have carpal involvement, If you have a Barton's fracture, you're going to get a volar subluxation, scapholinate instability, and so that we can see how that these associations with the carpus are really actually very important. And it's not just a distal radius fracture. This is a wrist carpus radius fracture. So in summary, there are osseous factors that are important. We think the architecture of the radius is critical, how it loads. We think in concept that the radius works more like this is a bone bridge. Osteoporosis and the mechanism of injury we can see here, and it creates these configuration of fractures that we see in our clinical practice. Ligaments are important. Ligaments, I think, are important for initiating the fracture with the tension band effect. The ligaments remain attached to these fragments and that they determine the settling position of the fracture, and so that when we have particularly a late case, we need to respect that to be able to elevate those fracture fragments, take into account that those ligaments are still attached, and of course the concept of ligament ataxis. And finally, the concept of osteoligamentous units, I think, is important and something that we need to do further work on to try and get a better understanding of putting this all together. So it's not really just going to be this distal radius fracture, but this also incorporates as to how all the carpal injuries occur.